Hello. Your doctor's diagnosed you with an abdominal aortic aneurysm. An aneurysm is an outpouching of a blood vessel. Similar to when a garden hose gets older or a bicycle tire gets older, it can pooch out to the side. And when that happens, the wall becomes weak. And as that aneurysm gets larger, the risk that it can rupture or pop, and you could bleed from that, increases. We know that when aneurysms are small, the risk of that happening is very low. But as the aneurysm grows over time, that risk increases. Sometimes we'll approach patients and treat them with surgery. However, surgery has its risks as well. Unfortunately, there's a 1 to 2% chance that you could die from surgery. So therefore, we have to be pretty darn sure that the risk of doing nothing is high enough to justify intervening. So when we look at patients, we look at the size of the aneurysm and the risk of the surgery. If this is the risk of the surgery and an aneurysm is small, the risk to the patient is low. So we usually choose a conservative treatment. We watch you. We keep an eye on the aneurysm and we see if it grows. If the aneurysm grows over time, at some point, surgery may be less risky than walking around with the aneurysm. And it's at that point that we talk to you about surgery. There are two types of ways to fix an aneurysm. There's the tried and true method we've done for over 30 years called open surgery. And there's a newer technique that's been done over the last 5 to 10 years. That's called an endograft, an endovascular aneurysm repair, or a stent graft. The less invasive technique can only be done in about 2/3 to 3/4 of people. So given the size of the aneurysm, we usually have to do a CAT scan called a CTA, which allows us to take a look at the anatomy and decide how we could fix your aneurysm. Can I stop for a sec?
Sure.
Now I'm going to do small aneurysm medical management. And then I'll pause. Then I'll do larger aneurysm, need a CAT scan. Then I'll have the results of the CAT scan, and I'll go through the options of how we do endovascular and how we do open surgery.
And will you divide those into two separate things? Or you're just gonna...
because usually I give patients the choice. They can have either, and they get to choose, because there's the benefits and risks in the short term and the long term. Fortunately, since your aneurysm is on the smaller side, it's best treated with medical management. We never know whether someone's aneurysm will grow over time or whether it will stay the same size. Because of that, we follow people periodically. We'll see you every 6 months if your aneurysm is between 4 and 5 centimeters in diameter, but only once a year if it's between 3 and 4 centimeters. At any point, if the aneurysm grows to over 5 centimeters, we may consider doing something, at which point we would get a CAT scan. All right, so next I am going to do the aneurysm is large and we need to get a CAT scan. The ultrasound that your doctor obtained showed your aneurysm was over 5 centimeters. And given that, we need to evaluate that further. I think you need a CAT scan. The reason for the CAT scan is, one, to confirm that the aneurysm is truly that large, because sometimes the ultrasounds can be off. And two, it helps us plan the procedure. As I said, about 2/3 to 3/4 of people can have an endograft. That's the lesser invasive technique. Everyone can have open surgery. The CAT scan allows us to differentiate who can have what and what techniques would be involved to do that procedure. So once you get your CAT scan, then we can talk further about what's best for you. I've reviewed your CAT scan, and your aneurysm is over 5 centimeters in diameter, and I think we need to do something about it. We fortunately have both options available to us. We can do open surgery, or we can do an endovascular repair of the aneurysm using a stent graft. There are benefits and there are risks to both. Let's go through each. Open surgery is something we've been doing for many years. Open surgery involves an incision on your belly on the left side. We approach the aneurysm directly. We take a graft that's made out of Gore-Tex that looks like a pair of pants. It has a common waist and 2 limbs. We approach the main artery in your belly, which is also like an upside-down Y, and we clamp the artery above and below, and we replace it, in essence, putting in new plumbing so that blood will continue to flow down to your legs. Once we're done, you would go to the intensive care unit, and we would follow you there for a day or two, and most people would then go to the normal ward. After about 5 to 7 days, you would go on home. This is a much bigger operation than the stent graft. A stent graft involves an incision in both groins, right on the groin crease or the bikini line. We find the artery there, and we take a graft that's shrunk down and crumpled up, and we put it in from the groins into the belly through the artery. And then we uncover it, and it springs into place. It seals the main artery above and below so that blood flows through the graft but can't get to the aneurysm. Unlike open surgery, where we sew it in place, an endograft is held in place by pressure so that the stent is sealed above and below. There's much less risk associated with a stent graft. Most people will go home the following day. So unlike with open surgery, where it's 5 to 7 days in the hospital, it would be 1 day in the hospital for a stent graft. The risks of bleeding, infection, heart attacks, etc., everything is less with an endograft. Everything except one, and that is the risk in the long term. Unfortunately, with an endograft, it's not sewn in place. Since it's not sewn in place, that graft over time can move. We call that migration. If it moves, blood can leak around the graft and get back to that aneurysm that we haven't removed. That happens about 20% of the time. So 1 out of every 5 patients that we operate on will need something else done in the future. Fortunately, most of those things do not involve surgery. They can involve catheters and angiograms. We would need to follow you if you had an endograft every 6 months with CAT scans and other testing to make sure that the graft is in the right position. If we did open surgery, we would follow you periodically with less invasive testing. Therefore, open surgery, you take a lot of risk up front, but there's less risk in the long term. Whereas with an endograft, you take less risk up front and more risk is shifted downstream. All right. Sure. Now that we've gone through the options for fixing your abdominal aortic aneurysm, I need you to go home, go through the literature that we've provided, and think about this. We'll confer with your medical doctors to see if there's anything else in your medical history that we should be concerned about and help you through this decision-making process. Okay? We good?
Yeah.
And I'm rolling whenever you're ready.
Hello. Your doctor diagnosed you with carotid artery disease. The carotid arteries are the main arteries that supply blood from your heart up to your brain. About 25%, or 1 out of 4 strokes each year in the U.S. occurs because a piece of a carotid artery narrowing breaks off and goes upstream, plugs up the artery, and causes a stroke. As the artery gets more narrowed, that risk of a stroke increases. There are times when we will actually do some type of intervention, such as surgery to remove the plaque or a stent to open the channel. When we do that, we know in the long term we can lower the risk of you getting a stroke. However, there's a certain risk associated with the procedure. Each thing we do has about a 1 to 2% chance of actually causing a stroke. So we have to be pretty sure that the risk of doing nothing is high enough to justify recommending some type of intervention to you. Your ultrasound shows that you have fairly mild carotid disease. Carotid disease has been evaluated to see what's the risk of our intervention and what's the risk of doing nothing. When the carotid artery narrowing is mild, the risk of the intervention is higher, and we watch you. You can have a stroke with any size narrowing. It's all a matter of the statistics. Since your narrowing is mild, we're going to keep an eye on you every 6 months with ultrasounds. The ultrasounds allow us to see how narrowed it is. If it gets to a severe narrowing, we may recommend an intervention. Your ultrasound has showed a fair amount of carotid artery disease, to the point that I'm considering recommending some type of intervention to you. I would like to confirm that ultrasound finding with another test. That's a CAT scan, or a CTA. And that's a CAT scan that looks at arteries and helps me decide how truly narrowed the carotid artery is in your neck. When you come back, we'll go over the options for treatment. The CTA of your carotid arteries shows a fair amount of disease. I think we're going to need to talk about doing an intervention. In high-risk patients, we talk about carotid stenting. In most others, we talk about carotid surgery, which is called carotid endarterectomy. Let's go through the surgery. If we do surgery, we do this with you awake. The anesthesiologist numbs up your neck, just like the dentist can numb it with Novocaine. You're given some Valium, you're given sedation, and then we have you tilt your head to the side and make an incision in the groove of your neck. The artery is just under the skin. We'll clamp the artery and open it up and scrape out all of the hardening of the arteries, the cholesterol and calcium plaque that's inside. We'll then sew it back together and take the clamps off. We'll close everything up and we'll admit you to the recovery room. Most people will stay overnight and go home the next day. We watch you for bleeding and clotting, which are the two ends of the spectrum when we work on carotid arteries. There's about a 1 to 2% chance of each. Bleeding is a collection of blood in the neck. Clotting is that risk of stroke associated with the procedure. We watch you for your blood pressure, and the next day, if you're eating okay, walking okay, we let you go on home. Carotid stenting is done with a puncture in the groin. So we numb up the groin right on the bikini line, just like a heart catheterization. And we advance a catheter up into the carotid artery in your neck. We put a stent, which opens up the blockage. In that situation, we also watch you for bleeding and clotting. The bleeding is in the groin at the puncture site as opposed to the neck, and the clotting is that risk of stroke, just like with carotid surgery. Most carotid stenting patients go home in 1 to 2 days as well. Hello. Your doctor has diagnosed you with claudication. Claudication is pain in your thigh or calf when you walk that goes away when you stop walking. Claudication is because the artery has developed narrowing from hardening of the arteries. That's the cholesterol and calcium buildup that can occur as you get older and can limit blood flowing down your leg. It usually impacts people's lifestyle. People used to walk miles and now can walk 100 or 200 feet. Claudication is not a limb-threatening condition. Are you okay?
Yeah.
I am rolling.
Okay. Hello. Your doctor has diagnosed you with claudication. Claudication is also called peripheral arterial disease, or PAD. It's when cholesterol and calcium, hardening of the arteries, builds up inside the leg arteries. It causes you to get pain in your thighs or in your calves when you walk. That pain goes away when you stop walking. We can watch you with this condition and try to affect your what we call atherosclerotic risk factors to slow down the process, or we can do some more invasive treatments to try and get you with a better quality of life and walking farther. The atherosclerotic risk factor reduction means we would like to slow down the hardening of the arteries. It's something that we can't cure, but we would like to slow down the progression. In diabetics, we want to make sure that the sugar is controlled. In people with high cholesterol, we would like to lower that. People who have high blood pressure, we'd like to bring that down. We want to make sure you're also on what we call an antiplatelet agent. That means aspirin or Plavix. We also want to make anyone who's smoking stop. When we do that, that will slow down the process. If your lifestyle is not altered by this, if you can get around okay, then we'll keep an eye on you every 6 months in the office. If, however, this is affecting your lifestyle to the point that you'd like us to do something, we have several options. One option is to try a medication called Platol. Medical therapy can take up to 8 weeks to work, and it works in about 2/3 of people. If you take the drug, you can walk usually 2 to 3 times the distance that you're doing now. To some people, that's adequate for what they need to do in their lives, and for other people, you need to walk farther. If you're someone who wants to walk farther, then we need to do something more invasive. Many people have heard of a heart catheterization. That's when the catheter is placed into a groin and goes up and evaluates the heart arteries. With PAD, we again go into the groin, but we evaluate the arteries from the belly down to the foot. We see where the arteries are open, narrowed, or blocked. And that allows us to see whether we can balloon the artery open, we can stent the artery open. A stent is a metal cylinder that kind of opens up and bolsters an artery open. Or whether the blockage is so significant we would have to do a bypass. Just like you can balloon, stent, or do a bypass in the heart, you can do that in the legs as well. If we do an angiogram, a catheterization, that's an outpatient procedure. You would come in the morning, you'd have that done, you'd be observed for several hours, and you'd go home. Most of the time, if we find that something can be treated with a balloon or a stent, we do it right then and there, so that when you leave the facility, you can actually get around better than when you start. If we find out that it's something that would need surgery, we'd have you come back to the office, and we would go over the options, and you can decide whether to go ahead with surgery or not. I'm going to pause there.
I am rolling.
At this point, I would recommend an angiogram. An angiogram is also called a catheterization or an arteriogram. This is an outpatient procedure. You come in the morning, the procedure is done, and you go home later that same day. Most of these are done with some mild sedation. You'll be a little sleepy, but you do not go to sleep under general anesthesia for this. When you come into the angiogram suite, we have you check in and go into the back. You'll change into a gown, and we'll put you on a stretcher. They'll start an intravenous in your arm and give you some sedation. We'll bring you into the angiogram facility, and you go onto a table. That's a special x-ray table that's kind of narrow. We'll numb up and put betadine or surgical prep on your groin, right at the bikini line or crease. And that's where we'll put in the catheter. The needle will go into the artery, and it'll allow us to gain access to the inside of the blood vessels where the blockages are that we're concerned about. This way we can see where the arteries are open, where they're narrowed, or where they're blocked. If we find some lesions, we can balloon them. That's where we inflate a balloon inside the artery, and it will open up the plumbing. Some blockages are more extensive, and it would need a stent. That's a metal cylinder that looks like a Chinese finger trap that will bolster open the artery. Some blockages are more extensive, in which case we can't do a balloon or stent, and that would need surgery. In those situations, the arteriogram would allow us to know the plumbing so that at a later point we could perform your surgical procedure. Once things are done, we'll bring you out to a recovery area. The sheath or catheter that we put into the artery will then get removed, and we hold pressure for about 10 minutes. This will allow a small clot to form and hopefully avoid any bleeding. Then, after we observe you for several hours, you'll be able to go on home. We'll call you the next day to make sure you're doing okay, and then we'll have you come back to the office in about 2 weeks to go over the results.